Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. In Bangor, Maine, public health officials are facing a devastating HIV outbreak. Aneri Pattani, a reporter with KFF Health News, talks to Stephanie Desmon about the circumstances that led to the outbreak and why those same funding cuts and policy changes could have impacts far beyond the state. Just a note that this conversation was recorded earlier in November prior to the reopening of the federal government and does reference the shutdown. Let's listen.
Aneri Pattani, thanks so much for joining me.
Thanks for having me.
So today I wanted to talk about an HIV outbreak that is happening in Bangor, Maine. I want to talk about it specifically, but I also sort of want to get to a bigger picture of what it's telling us. So I'm wondering if you could just sort of paint the landscape of what's going on there.
So Bangor, Maine, which is one of the bigger cities in the state alongside Portland, Bangor is a lot further north, is dealing with that city and the county it's in is dealing with an HIV outbreak that has been going on since October of 2023, so about 2 years at this point. They've had, over that time frame, 29 positive HIV cases. That is compared to, in a normal year, they would have about 2. We're talking about a significant outbreak. All of the cases, or the majority of the cases, have been among people who are using drugs, and many of whom are homeless or living on the street. So it's been a real public health crisis for this area. And at the same time, they are juggling with a lot of issues that a lot of rural places in our country are dealing with, lack of access to medical services, poverty, homelessness, and a lack of housing, issues with harm reduction or harm reduction services that include like syringe services that can be key during an HIV outbreak. And so there's a lot of local politics, a lot of local systemic issues all coming together, contributing to this outbreak.
Let's touch on homelessness first. So how is this related to homelessness?
Most of the cases, vast majority, are among people who are homeless in Bangor, Maine. And they believe, the city officials that I spoke with, the local advocates that I spoke with, that a lot of the cases came from one particular encampment called Camp Hope, or Tent City, some folks called it as well, in the area. And a lot of people there, living together, you're sharing tight quarters, you don't have great sanitation, people are using drugs together. So it was an area for things to easily spread among that population. At the same time, the fact that people were all together meant that services could be delivered to them at one place. So a lot of the social service organizations, the people trying to get folks onto PrEP to prevent them from becoming infected or give treatment shots afterwards, could all go to this encampment. However, the city earlier this year disbanded the encampment. And that kind of scattered all these people, several of whom were newly diagnosed, all over the city and the county. And the city lost track of a lot of those folks, making it hard for social workers to follow up with them, for medical case management to follow up with them. And a lot of the advocates I've spoken with say, that worsened the outbreak.
And that seems to be sort of the trend, right, in cities and I guess rural areas too, to break up homeless encampments.
Yeah, we've seen a lot of that, both from sort of conservative and progressive areas, city level, state level, a lot of officials working to, we don't want to see the homelessness. We don't want this all gathered in one place. It's a safety issue. It's a public sanitation issue. Whatever it is, there's been a lot of efforts to disband folks. And we've seen that from the federal level as well, with the Trump administration saying, we need to clean up our streets. In Washington, D.C., where I live, they have had federal law enforcement clearing encampments and moving people and saying that they should have access to treatment or they should be involuntarily committed to addiction or mental health treatment. But also if they don't agree to that, they are simply pushed out. And so I think there's been that trend all over our country. And what we see in Bangor is sort of one of the possible outcomes or effects that can have when you have an outbreak. It's not that, disbanding the encampment did not spark the HIV outbreak, but it did make it harder for folks to access resources and kind of increase the potential geographic impact too as people go further and further from Bangor. If someone tested positive now goes down to Portland, Maine, they could, in theory, spread the outbreak further.
Now, I know that we used to call them needle exchange programs. Now we call them syringe services programs. There was an issue with those in Bangor as well. Is that correct?
Yeah, so this is another factor that a lot of folks in the area that I spoke with talked about contributing to the outbreak. So Bangor had a few different syringe service programs, one of which, due to its own mismanagement, financial issues, shut down on its own and had been running out of supplies in the lead up to this outbreak. So some of the folks who worked there, staff members actually said, the times that we were out of supplies to give people who use drugs coincided very closely with when these first cases started coming up. And they saw a link there that hey, if people did not have clean supplies to use drugs, they were sharing needles or they were reusing supplies, things that increase the risk of HIV transmission. So that was sort of one issue. The second thing is there's another syringe service program in that area called Needlepoint Sanctuary. It was certified by the state. However, city officials had not wanted them to operate in certain areas like public parks in front of the library. And so there were a lot of city ordinance fights with this syringe service program, and they weren't able to operate for a while. They even found this brick and mortar location, but then the city said there's a zoning issue, you can't operate there. And so it was effectively shut down in the middle of this HIV outbreak when there's a lot of research that shows that syringe service programs giving people needles and other supplies so that they are using new and clean needles and not sharing with other folks is a way to contain any sort of outbreak.
And are these also targeted, say, during a lot of the cuts we've seen to Health and Human Services?
So they haven't been yes and no. Sort of, it's hard to see in all the financial cuts that have been coming from the federal administration. It's sort of we're still trying to see what is left and what has been impacted. And the court cases with the back and forth is sort of hard to say. However, what has been clear from this administration is that they do not like harm reduction. The Trump administration has come out and said, harm reduction is enabling illegal activity. They kind of equate it with an increase in crime, despite the fact that research does not support that.
Could you define harm reduction for those of us who aren't familiar?
Absolutely. It sounds like such an easy question. It's actually quite a tricky thing because a lot of people have varied thoughts on this. But at the simplest level, what I will say is that harm reduction are efforts, often in the public health realm, that try to keep people who use drugs safer as possible and alive. So that often includes things like naloxone. A lot of people know it as Narcan, the medication that when someone has used drugs and is overdosing, used opioids, it can reverse that and revive them. That's an example of harm reduction, giving folks syringes so that they have clean supplies to use and reduce the spread of infectious diseases, harm reduction. So that is the topic that has become very contentious at the federal level. And with the federal administration coming down and saying, we don't support this, it's had a chilling effect. Because concretely, historically, the federal government has not funded syringes. Federal dollars from the vast part of the past few decades cannot buy needles. You can't buy needles with that. But what has happened additionally is the administration coming out and saying, hey, we're not sure we really support programs that fall under this umbrella of harm reduction, has been interpreted by people in many different ways. And so you're seeing that chilling effect at state and local levels.
And again, that's beyond Maine.
Yes, exactly. So you're seeing that all over the place. I was recently, in the South doing some reporting, and there are a lot of groups there that are saying hey, we're hitting up barriers with our state feeling less certain about funding us now, or we're being more careful about where our data is because the people we serve might be targeted for criminal activity.
It feels like this outbreak really could teach a lot of lessons to others about what to do in this situation. What are the lessons that you take away?
Absolutely. So a lot of the experts that I spoke with talked about what we're seeing in Maine is really a confluence of local issues. The fact that there were local issues that led to the closure of a syringe service program and that, barred another, that led to the disbanding of this homeless encampment, that led to a decrease in medical case management services for people with HIV. However, there is a stated goal from the federal administration to kind of replicate those policies elsewhere. There's a goal of decreasing harm reduction. There's a goal of disbanding homeless encampments. And so a lot of folks in Bangor said, this is what we're seeing here as a reflection, as a consequence of local policies. If we make those national, could we see more Bangors happen, more outbreaks like this happen all over the country? And I think for some folks looking at the situation, that is the fear.
And going back to harm reduction for a second, the idea essentially is that we've tried to keep people from using drugs completely, and it hasn't worked. So why don't we make the experience at least safer for those who choose to engage in that behavior? Is that right?
That's correct. And I think I was just recently speaking with a doctor about this, and they were saying, a lot of medicine is kind of this way. If we think about, someone with terrible cancer, it's incurable. You're not going to fix it, but can you do something to make their quality of life a little bit better, to make sure they live a little longer? For someone with high blood pressure, can we give them a medication that means they can sustain their day-to-day? We could ask them to, completely change their diet, never have salt in anything ever again. But realistically, we want to work with people where they are and make them safer in that way.
That was a great analogy. I'm curious about, as we talked about the health cuts before, now we're seeing the effects of a shutdown. Are those having similar chilling effects?
I think it's hard to say, at least from my own reporting right now. A lot of what we're seeing from the shutdown is it's affecting people's livelihoods, right? People who are federal workers aren't paid. People who are contractors are at risk. We might see SNAP benefits being hit. And when we see poverty, everything is stretched, right? Social services get stretched thin. Food banks are running low. People and, housing insecurity increases. All of these factors, coming from a public health perspective, they're interlinked. So is it, losing food stamps causing someone to develop HIV? No, of course not. However, when someone is on the brink of poverty, right, every little thing that gets chipped away from them, every resource that gets taken away, increases their risk to be in a more vulnerable situation. Maybe then they end up in an encampment where there is an outbreak. Maybe they are then, forced to be in a situation that's just going to elevate their risk.
What can communities do when they're faced with this sort of situation?
So I spoke with a researcher at Tufts University, and he was really clear that the research around HIV outbreaks, big ones we've had in the past, Scott County, Indiana, one in the Merrimack Valley of Massachusetts, shows that the biggest thing communities can do is fund syringe services programs at those times. In Scott County, Indiana, there's this interesting research study that shows a graph of the cases, and you see cases go up, 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 and then at some point they introduce a syringe service program there, and that is when they really start falling. So you can kind of see in real time the evidence of people are using drugs. You know that when the outbreak is among those people, the best thing you can do is give them clean supplies so that the infection is not spreading to new people.
Are there any other measures people can take?
Certainly, I know the health department in Bangor, as well as the Maine CDC, which is their state health department, has been talking about just trying to shore up medical services more generally. If you find people at risk and can get them on PrEP, which is preventative medication, so that they are unlikely to get HIV, that's the best, right? Prevention is always the best medicine, that you stop it before it starts. It's really cost effective compared to treating folks for HIV or hepatitis C. Community health centers, federally qualified health centers, places that can connect with folks who are on the street or, are not already engaged in care, to get them these prevention tools, to also get them testing for HIV and STDs. All the sort of really basic but crucial public health interventions, that's what the state and the city health department are looking to do. And that's what I think a lot of health departments across the country are trying to do with really, really meager resources. So when they are cut, these are the things that don't happen. But these are also the things we know if you can get them in place, the likelihood of having an outbreak or having a situation like in Maine is less.
As for Bangor, what have you learned since your reporting finished?
So there are some signs of positive momentum I've been hearing from folks in the area. One of the syringe services programs, the one that I had mentioned that the city had sort of curtailed and didn't want operating certain places, the city council just this week actually voted to rectify the zoning issue. And what that means is that program will soon be operating, and they will be able to provide clean, sterile needles to folks who need them in the middle of this outbreak, which is, again, one of the most proven interventions to stop its spread. So that's some interesting news. And then secondarily, the city decided to use some of its opioid settlement money to hire 2 case managers. And those folks have been hired, and their job is to go out onto the streets and find the folks, many of whom were disbanded from that homeless encampment, find them where they are now and connect them to social services. If they are HIV positive, get them connected to treatment. If they are not, get them connected to prevention and PrEP. And then there's also a regional HIV case management center that had shut down, that now another entity agency in Maine has taken over those responsibilities and is getting services up again. So there are reasons for hope in that outbreak.
I think this is a fascinating story, and I think it's because it's really a warning that if these kind of policies go into place, these are some of the things that can happen and can happen quickly. So I appreciate your work on this very much. Aneri Pattani, thanks so much for joining me.
Thanks for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmon. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.